EM board bombs.
Welcome back to EM Board Bombs. We haven't left. We know you have managed your life accordingly, waiting on the edge of your seat for part 2 of Precipitous Delivery. If you noticed on YouTube, we are wearing the same shirts. That's because we haven't showered, haven't slept, haven't left our chairs in over a
haven't.
week.
I'm just hooked up to a PureWick, starving to death.
A PureWick. Man, I should have invented the PureWick. Do you know how many people on a daily basis ask me, like, this is amazing. Can we buy these for home use? And I'm like, I don't know. Like,
You're like, yeah, I see them advertised to me on Hulu all the time.
Are they really on Hulu?
Yeah,
That's
there's
funny.
commercials.
I don't have Hulu, but
yeah.
Hey, so if you haven't listened to part 1, you're going to get quite a shocker intro here. This is part 2 of Precipitous Delivery. We're going to dive right into it here. Some say FedEx is fast. Some say same-day Amazon delivery is fast. But if you're a certain person coming to the ED with a precipitous delivery, you might just deliver in 12 minutes. And your job as an emergency doctor is to take care of that patient and the subsequent baby that they deliver.
Both patients.
2 for 1.
Mm-hmm. This is the ultimate twofer. This is not your twofer pediatric visit with Kylie and Kyler, 2-year-olds with a runny nose. This is the twofer new mom, new infant.
Right. I'm just wondering how registration would work too. Think about it. Remember, when you have like a trauma patient or a resuscitation patient, they don't have time to register them. They create like a, an alphanumeric like name or something. And like they rush in with the wristband and the stickers for everybody. Can you imagine what it would be like for a little baby? And it's like, oh, we got a new one. Congratulations. Another patient just showed up.
Like you're like trying to like clip the cord and registration's like pushing themselves in the room being like, no, let me put the bracelet on.
What insurance carrier do you have? Yeah.
God.
What is your preferred pharmacy? Yeah. Anyway, so
here we are. Yeah. The last episode we covered the patient presenting and the questions you need to ask and your initial assessment. And now we're going to actually talk about the delivery.
And now we'll talk about the scariest part of it. Mm-hmm. So before we dive into that, who do we need to give credit to?
We need to give credit to EM News, our amazing solo sponsor, who is so fantastic. They give, free issues and online access to any emergency doctor, cover lots of different topics like cases, opinions, new research. Check them out if you haven't heard of them, emnews.com.
Check them out. Absolutely. Totally agree. And then, of course, EM Rapid Bombs. Check that out. You can go to emboardbombs.com. EM Rapid Bombs is those 2 to 4 minute episodes allowing you rapid review of not just board stuff. I mean, the whole nature of the podcast is prepare you for boards. We have over 450 or so episodes. Pretty awesome. But also we tell you separating what is important in real life. We definitely tell you in these questions on these episodes, like, hey, listen, like in real life, you would never do this. But on the test, you got to know this. So not many people are doing that. We're the only question bank podcast, definitely, in the world. Mm-hmm. So check us out. We've got great listenership.
You sign up today. You get to keep the price that you sign up with. We're not Netflix. We're not
lock yourself in.
Yeah, not going to email you every few months raising your price. You get this price now, and then no matter how many more episodes we add, you will keep what you sign up with. That is an important point.
I got rid of my Netflix for that very reason. I got so mad at them when they did that.
It's offensive.
And I've been better since then. So here I am recording a podcast on Precipitous Delivery. Clearly I'm living my life correctly. So last episode we said the ultimate question was what?
Do you have time? Or
to transfer?
Do you have time to work with? Or is the delivery happening?
Delivery happening. And the 3 questions were what?
The 3 questions were, is the mom like feeling contractions and pushing with it? Mm-hmm. Is the fetus visibly emerging? Do you see a head coming from the vagina?
Yep.
And
exactly. Then of course, if contractions are they more than 2 minutes apart or not?
Are they back to back? Yeah.
Yeah.
So let's assume all of those things are yes.
All those things are happening.
You don't have time to work with. You're going to deliver this baby.
You're on your own. We talked about things on the ultrasound you have to pay attention to. You're doing the ultrasound first. Got a pregnant woman about to deliver. Ultrasound first. Number 1. You're looking at the position of the fetus. Is it a vertex position? That means head down, head first, whatever. You're going to look for the placenta. Is it low lying? Is it a placenta previa? And then you're going to get fetal heart tones. If you have a low lying placenta, you're done. Call it quits. You cannot deliver that patient. You cannot do a vaginal delivery. And then after that ultrasound is done with no placental previa, you are allowed to do a gloved, sterile gloved vaginal exam, and you're going to palpate for presenting part, fetal head. Hopefully, you're going to feel the fetal head. If you feel a cord prolapse or any type of umbilical cord, or you visualize umbilical cord, you're also done. Stop whatever you're doing, no delivery. You're going to elevate the presenting part, the fetal head, with your hand, shielding the umbilical cord from compression. And then you or an assistant needs to keep doing that, essentially until the C-section happens. That's a long way away, potentially, for some people. It doesn't matter. You're going to stand there as long as you can, and then try to prevent delivery as much as possible. Okay, there's something else you could find up there that's not good, and we left you hanging on the last episode here. What is that?
I mean, there's a lot of things you could find, i.e. any body part other than the head.
In this particular case, in a delivery of a newborn, let's stay simplified here, not in the strange world we live in.
Yeah, something else that's not a newborn's head is like their foot.
Yes, that's not good.
No, that's
at all.
That's a breech delivery, which, according to the research, is like 3% of all deliveries.
Yes, that is the research.
We'll see.
So what do you do if you see that?
Don't touch it. Don't pull traction on it.
If ortho were here, you'd have to keep them away. They'd be like, that's something to pull on.
Don't do that.
Axial pull, closed manipulation.
Yeah. It depends. Like, is it a foot? Is it a butt? Is it one leg? Is it a knee? Is it the other? Like, there's all these different ways to deliver breech. It's way outside the scope of what we're talking about. And that would be a different episode. So we're just going to say, don't do that.
Again, we have a study guide on precipitous delivery. So check it out if you want to review or re-listen to this with the review if you want. My father, who's an MFM, internal fetal medicine specialist, he helped me write that review. He's actually one of the authors. It's funny. It's one of the few, well, it's actually the only authorship of Dr. and Dr. Briggs on the review. And so it was an honor to have his expertise in that area. But it was so funny as I was walking through these scenarios with him. I was like, okay, let's walk through. What if you have a breach? And he literally said, that's a very bad day for you.
Oh my God.
He's like, then you are really out of luck. Because I said, like, what if you're alone and you have a breech delivery? And he's like, I would be sweating.
Oh, yeah.
So scary stuff here. Yeah, don't touch that. Don't deal with that. Try your best to get OB as soon as possible there to ED. Try to buy yourself time.
What's the other thing that you also would not want to touch if you see it up there?
Cord prolapse.
And?
Foreign bodies.
The bulging amniotic sac.
Oh, that too. Yeah, don't do that.
Yeah. Don't mess with it.
Don't mess with it. So let's prepare your setup. Set up the room for delivery.
Yeah.
You want a big as room as possible. Your bay. There is go to the bay. There is a large bariatric room in the ED that I call the Lincoln Suite because it's like that big. I'll walk in and tell the patients all the time because we put random patients there. I'd be like, you guys got the Lincoln Suite. Congratulations. And they always laugh. They love it. So if you have a Lincoln Suite in your ED, use that, the big suite, the double room. So precipitous deliveries can make the ED staff really anxious. So as the physician in charge, your job is to control the room as possible. You're going to be nervous too. I would be nervous. So your job is to keep everybody as calm as possible. And you're going to remove the patient's clothing, get them in a gown, properly put them in a properly lit room, get sterile gloves, lots of absorbent pads to place into the mother, and then try to get a pelvic bed. Those are usually standard in most ED beds. They have some type of stirrup setup or the ability to do stirrups. So get a pelvic bed. You're going to need that. Now, the best position is a semi-sitting one for the mother with hips flexed, abducted, knees flexed. This is called the lithotomy position, the standard delivery position. And many hospitals have some type of birthing kit if they have birthing capability, and that can be delivered to the bedside. So if you have that and the OB's not there still, to say, hey, just go to an LOD suite, ask the tech to do it. Give me some type of birthing kit. Give me some type of standard kit, almost like the chest trauma kit. And it has like everything you need to open the chest up. Very different thing.
Yeah.
You're not doing that in this case, but the birthing
Don't get
kit.
confused.
Don't get confused. Don't get the don't get any trocars. But yeah, you need the birthing kit. Okay, great. What if you don't have the birthing kit? There's obviously people listening to this podcast are like, yeah, that's wishful thinking. I don't have any of that.
Okay.
There's some simple tools you need here.
Let's go. Let's make a list here.
Okay, cool.
A quick hit list.
Get your notepad out. Okay.
Yeah.
Notepad.
What's your
pen?
birthing kit?
Here's my
My
ball pen just clicked.
He's ready to go.
Ready
Lots
to
of
go.
gauze sponges.
Okay.
Lots and lots of gauze.
Check. Lots of gauze.
Yep. Sterile gowns and gloves.
Okay. Sterile gowns. Got it.
2 sterile clamps and sterile scissors to cut the umbilical cord.
Got it.
A red top tube to collect umbilical blood from the placental end of the cord.
That sounds like above and beyond. Like if you deliver this baby and you did that and the OBGYN showed up and you're like, here's your umbilical blood.
I mean, that would be like that's big energy.
That's a mic drop. That's a mic drop.
You could do that. You
Okay,
can put
keep
it on
going.
your
What
list
else?
with like a little question mark. Clean towels and sheets for the baby.
Good. Not dirty.
Warm
Clean
blankets. And then a bucket for the placenta and the cord. Don't just let that fall on the floor.
As an academic attending, I'm really good at getting warm blankets. That's something that I excel at. So I got that down.
Yeah. I mean, if you have an infant warmer, obviously get your infant warmer in there. It'll have all the stuff you need for the baby. I think most places have those. Although one place that I went to, I noticed they had a perimortem C-section kit. And I said, where's like the infant warmer? And the nurse goes, I guess we could just put it in the blanket warmer.
Oh my God. Doors open, of course. Doors open.
Yeah.
Yeah, that's pretty bad. I'll never forget the first precipitous delivery I had. I was still a resident. I was at Wake. And everyone, if you've been to Wake, you know the setup there, the ED, nice little curtain rooms. And I remember I walked into a room. The patient was like, I feel like I have to have a bowel movement, the classic story. And then talked to her further. She said, yeah, I might be pregnant. And yes, I may or may not be about to deliver in 5 minutes. And got the ultrasound, did everything we talked about, the steps. Everything looked really good. And she was crowning at that moment. And I remember I walked out and I quietly found our most experienced nurse, not even in that zone. I walked up and I said, we have a patient in room 5 about to deliver. I'm just letting you know. We need to quietly get the baby monitor. Because I noticed that if you say that out loud or something, it's just going to set an aura of just like stress and complete chaos. Mm-hmm. So I quietly told this nurse. She quietly went to go get, equipment, quietly told the charge nurse. I quietly paged OB. Like everything was just like very calm and collected. And then all it took was when that nurse went to go get the baby warmer and had to roll it down the hallway. And that like is everybody. Everyone sees it. It's this public main hallway in the ED in front of all the curtain rooms. And then everyone's heads turn. They're like, why is a baby monitor going into this room? And so I walked in there and then I quietly told my attending, hey, there's a baby about to be delivered in this room. Everything's under control. She's okay. I'm calling OB. They'll come down and help. And OB came down. They were very nice. There's an OB resident. They're like, you can still deliver the baby. We'll just be here. We don't really care. And we did it all. Everything was fine. Fun story though. But yeah, when that happened, it was just like, environmental services stopped doing what they were doing just to come and watch. It's just like everything just like stops. It's almost as crazy as, like the precipitous, like, chest trauma, gunshot wound where they're opening up the chest. There's unfortunately a lot of bystanders, which is completely inappropriate. Of course, it's patient privacy. So do your best to control the staff. Do your best to make sure that there's privacy and control of the room. Kick people out that shouldn't be there. Absolutely. Cool. So let's go through the delivery procedure. There's essentially, 10 steps here?
Yeah.
Nice even number of steps. So we'll go through each one of them here. Why don't you go through them and I'll number through them. As in, give you cues. Okay, let's go.
So number one. The mother's going to need to bear down and push. She'll push with the contractions and the pressure with the fetal head. Ask her to like pant kind of like a dog through the peak of her contractions and rest in between with normal breathing. That'll help make her contractions better and give you some time. Sit on your stool in front of the mother. Don't take your eyes off the perineum, especially if she's pushing. You should see it bulging.
Never.
You'd be surprised how fast they just, once they're in the canal,
they shoot out.
Whoosh. You don't want to be sitting right there and not be ready.
Especially in a woman who's delivered before.
Yeah, that'll happen for sure.
Just
so be ready. Keep your eyes on the prize. Step 2. If crowning is present or the fetal head is visible, there's nothing stopping the delivery at this point.
We've covered that.
Time to control it
You're
and
done.
guide it. Yep. So now you're just safely guiding the fetal head through descent and avoid causing any vaginal trauma. Give some perineal pressure. 3, place one hand on the
Easy
crowning.
so far.
Yeah, it's preparing. Place one hand on the crowning portion of the fetal head. Now you're touching the baby. Okay. Mm-hmm. Apply light pressure just to maintain the head in a flexed position and to slow the descent. Again, you don't want it to just shoot out. You want this to happen in controlled
No skid
manner.
marks. No skid marks.
Yeah. Mm-mm. The fetal head it's usually facing the mother's back when it first comes out. Never pull on the head. Again, no ortho, no traction.
No pulling.
No traction. And again, if it's another body part coming out, don't
do anything. Just don't do anything.
Step 4. After delivery of the head, it normally rotates to one side. I remember they used to always ask us, like, after we delivered the baby, like, which was it, LOA or like all those things. And I was like, I don't know. I'm just handing you a live baby and everything is good. And that is the question.
Thankfully, no one in the ED here is ever going to ask you that.
Yeah. So don't worry about that. This is not your OB rotation. So it'll rotate to one side or the other. You're going to feel for a nuchal cord at that point, which would be the umbilical cord around the baby's neck. If it's loose enough, you can unloop it. There may be 2. You may have to unloop it twice. If it's really tight and you can't fit you can barely even get a finger underneath it, double clamp it and cut it right there. But remember that now you've just cut off the baby's blood supply as well. So keep that in your mind.
That's the scary step. We don't want to minimize that, of that being a very scary moment, even though it's not going to be the majority of cases. We can't really tell you, it's case by case, what to do in that situation. If the baby seems to be descending down well and there's a tight nuchal cord, you can clamp it, hope for the best. You can unwrap it from the head. Go ahead and do it. Clamp it, cut it, and get the baby out as quick as possible.
Yeah.
Step 5.
Step 5, delivery of the shoulders. So the next push, the head is already out. You're going to guide it downwards. So the anterior shoulder is going to slip under the pubic symphysis and deliver. Then you'll guide the head upward to deliver the posterior shoulder. So this is the AP delivery. Mm-hmm. You're doing the anterior, then the posterior shoulder. If the shoulder does not deliver easily, you may have a shoulder dystocia. It's rare, but it's critical. You should know these steps.
This is a board question.
And this is definitely a question. So there's a couple things you can do. Have your assistant sharply flex the mother's thighs and have her push again at the same time as you're applying suprapubic pressure with the palm of your hand. And this is sometimes why I've been taught that you should have a stool right next to you at the bedside, because if unless you're a super tall person, you're a regular height human,
I'm not.
Dr. Briggs.
Neither is Eltavot.
You stand on top of a stool so that you can give really aggressive suprapubic pressure. And remember, this is suprapubic pressure, not fundal pressure. That's later.
Correct.
So push down hard. Someone's flexing her thighs, have her push. And that's successful 90% of the time in a shoulder dystocia. So that's called the.
And it's all you need to know. There's some other weird steps you learn as a med student. Just forget about it. You're not going to be doing any of that crap. Sorry.
Yeah.
If you got bigger problems if that's not working.
Anterior shoulder, posterior shoulder, McRoberts if needed. Once the head and the shoulders
are out. Such a board question.
It absolutely is. I would say that and the G's and P's.
Yeah, and then the cardinal movements of fetal delivery. Those are really the 3 biggest questions. Cool.
So,
all right.
Once the head and the shoulders are delivered, 6, the body should come easily. Hold the baby properly. One hand is on your upper back, cupping the nape of the neck with slight extension to encourage breathing. And then the body is supported by your forearm. So I wish I had my dog here to show. He's the size of a newborn baby.
Yeah.
But again, with your stuffed animal that you carry with you at all times, you can try that.
Just practice.
So you're supporting the body with your forearm, cradle it against your body. These are slippery. They're super slippery.
They're so slippery.
Don't drop it. You just got it out. Everything is good. Don't celebrate yet.
Yeah.
Again.
That's like that thing in football. Every year it comes up. The ball player dropping the ball before they cross the goal line and they fumble it because they're about to celebrate. They're literally about to do their crazy celebration. And people always ask on the internet, and I'm asking too, why can't you hold on to that ball until you know you're in the end zone?
Yeah.
Anyway, people that watch football understand, but it's just obnoxious. So this is the same thing. Don't drop the baby.
Yeah. Don't celebrate too early. Hold the baby. So, and now you have your second patient.
You got the worst part over with. Part over with. Well, hopefully.
7. Hopefully that's the worst part. Yeah. Now you're just going to do some basic neonatal resuscitation. If you need to, you can use bulb suction to clean out the nose and mouth. That's a different review. And remember, that's bulb suction. Don't put a yank hour in the baby's mouth. God.
Yeah, just septoplasty.
So, you're stimulating the baby. We'll do a whole nother review on neonatal resuscitation. Mm-hmm. Step 8, deliver the placenta.
Mm-hmm. Key factors here. I was just so enthralled by this next step. As a med student, this was what you looked forward to the most. You're like, I get to do something.
Let you do this. Key factor, be patient. Don't pull on the cord. Placental separation should occur within like 10 minutes of the delivery. If it's been 10 minutes and it hasn't delivered and the cord isn't like lengthening, you can start very gentle traction, ask the mother to push. You should really like up to 30 minutes of like gentle traction.
No one's patient about this ever.
Yeah. And 30 minutes is longer than you think. So this is another situation where it's nice if you have more than one physician in the room, because someone's doing the neonatal stuff. And why in the beginning your number one step in our first episode was calling for help. Exactly. Even if it's just like you're in a critical access hospital and you called for help by calling another doctor that lives in the area, like literally anybody that can get to the hospital. Or just some pediatrician or something. Yeah. So like we said, it can take up to 30 minutes. There's no benefit to rushing that as long as there's no hemorrhage happening. You don't want to avulse the cord. You want to be able to remove the placenta easily and not have to manually do it. So signs that the placenta is being separated from the uterine wall is that gradual lengthening of the cord, and you may have like a small gush of blood and change in the shape of the fundus.
Right. Boom.
All right.
9. We're getting there.
Start IV Pitocin once you're convinced that the placenta is detaching. That is 20 units and 500 mLs crystalloid over an hour, followed by the second dose.
Don't memorize that.
Don't. Just look it up. Standard reference dose, but it's Pitocin. Causes the uterus to clamp down and the vessels to vasoconstrict. You can massage the fundus. You want it to feel firm. If you have a boggy, flabby fundus that is not changing in size, that suggests atony, which is the most common cause of maternal hemorrhage. Yep. Definitely.
Most common cause of maternal hemorrhage, atony, uterine atony. Boom.
And here's
not lacerations.
Something else that I learned in a terrifying way was a uterine inversion that happens at this point. If it happens, stop the Pitocin so that you can push the uterus back in, because if the Pitocin is going, it's harder for you to push the uterus back in because it's all contracted. So
fun
hopefully
facts.
you don't ever have to do that. But fun.
Adding to the nightmares.
Yeah. So what's the last step, which you may feel like you're home free, but hey, guess what? Maternal bleeding, huge cause of mortality in deliveries. So you, again, don't celebrate too early. Number 10, what is the most common cause of maternal bleeding? We just
uterine atony.
85% of postpartum hemorrhage.
That's a lot of people.
Huge. What are other causes?
Well, we got lacerations. I mentioned that earlier. Tears. Mm-hmm. Those are the big ones, really. Yep. And of course, like, they have a history of Malloy-Brenn's factor deficiency or something, high risk. That's the most common blood dyscrasia. Love to say that.
And then make sure the placenta isn't like one pretty piece, that you didn't just pull out like a chunk of placenta and now there's like retained
parts, retained products. Yes.
Yep. If there are lacerations, you can wait for the obstetrician. You don't have to do it yourself. Although one obstetrician told me once that just like throwing in some Vicryl, because quote unquote the vagina is very forgiving. But really no, wait for OB.
Things you learn on EM board bombs. Should that be the title of this episode?
The vagina is forgiving.
Yeah, we may get flagged by Apple Podcasts.
Oh gosh.
Anyway, okay, awesome.
Just hold pressure if you need to stop bleeding. Pressure. Do like we always
Unless
do.
Unless you're dealing with life-threatening bleeding, throw pressure.
Yeah. Hold pressure.
Yeah.
So what if you do think you have retained products?
Ultrasound is so helpful here. It is so easy. You already got it at bedside. It's right there. You were using it a minute ago. So the uterus should have a thin endometrial stripe on ultrasound after the placental delivery because nothing's there anymore. And the uterus is still pretty large. It clamps down quickly after delivery, but it's still bigger, obviously, than it was when a patient's not pregnant. And so it shows up pretty easily on your ultrasound because there was, a large fetus just in there a minute ago. And so what you're going to do is look for that little strip in the middle. These are easily Googleable photos, again, using my word of the day. So what you can see is that thin hyperechoic stripe on the ultrasound, and that's normal. There's nothing there. If this is not seen, or there's a bulge in the middle of the uterus, or it hasn't clamped down completely, that's very concerning for retained products, and that might require manual removal by hand. Again, wait for an obstetrician to do this if possible. Do the best you can to just hold pressure. If the patient's unstable, of course, you're giving blood products. But you're going to wait as much as possible if the patient looks fine. Mm-hmm. In the meantime, you could, tamp on the area by packing it as much gauze as possible. But again, waiting for help as much as you can. Wow.
And that's it. That's 10 great. Steps. You did it.
Piece of cake.
You didn't drop the baby.
Now go empty the lobby.
Yeah. By the way, the patient that's been waiting to see you about their stuffy nose and earwax for the past hour is very angry, and they're threatening to call patient relations.
It's so funny, isn't it? Yeah. They're the cousin of the CEO, and they don't understand why you haven't been in the room yet to order their MRI nose. I love this job. It's a great job once you get over that.
Yeah.
That is so awesome. Cool. That was a great summary, and people should bookmark this. They should listen again to it. And we'll have some rapid bombs covering some key points of this too. So if you're a premium subscriber, you get some extra details on how to manage these patients. Hopefully we'll do that here in the future. That's really about it. Check out EM News. Check out EM Rapid Bombs. I really was thinking in the middle of this as you're going through it, can you imagine like the intern that just started listening to EM Board Bombs? Like their friend, senior resident said like, hey, check out EM Board Bombs. They cover some really good stuff. Especially as an intern, you're beginning. They hit the subscribe button. They're like, okay, what's the first episode? They're like, oh my God. Like they get pale, they get cold and clammy. They're like, this is emergency medicine. I have to deliver babies.
Yep.
I didn't want to do OB.
What's funny? Our OB service has like a PowerPoint that they send to all of their residents when they do the like L&D triage, and the title of that is "But I didn't want to be an emergency doctor." And I was like, that's us when fantastic. we see this, we say, "But I didn't want to be an OB guy."
It's so funny. It's so funny because we have OB residents that rotate with us their intern year in the emergency department, and I always feel bad for them because I'm like, I walk up to them like, are you ready to see male patients? And they're always like groaning like, oh, fine, But it turns out, I don't know what it is. I don't know if it's just, obviously it's a testament to their work ethic. I love working with them. They get the most intubations out of any other resident on our service. They have the record number. There was one OB resident who got 7 intubations in 2 weeks on our service. We kept joking around whenever she comes downstairs for pelvic. Now that she's an OB resident, we're like, you should stay around. There's an intubation coming in if you want to get it. And she kind of like says, you know what? They're actually pretty fun. I agree.
That's awesome.
She's a triple threat.
I love that.
Does EM, critical care, and OB. Wow. All right. Yeah. That's it for EM Board Bombs here. Again, Dr. Wasiski-Kuhn, thank you so much for being with us. And it's been an absolute pleasure as usual talking about a serious problem. Hey, I think we should talk about another nightmare situation, which is dealing with the neonate in the room that's waiting for you to see them. Ooh. So we'll deal with neonatal resuscitation in the near future. Let's take a breather. Maybe next week we'll talk about I don't know, stuffy nose.
Stuffy nose, earwax removal.
Earwax removal. That's good. I like that. That's a rapid bomb actually we did. All right, cool. We'll see you next time.